Hello, everyone. All right. Welcome to my presentation for our course development project. My course is Advanced Topics in Athletic Training. So kind of a brief overview. Well, what's my course? My course is an elective course that focuses on overuse lower extremity pathologies. The hybrid course, so it's online and in person, but primarily it is online. And it's essentially a course to help introduce students to learning after school ends. So what it's like to gain CEUs, what it's like to learn in non-traditional environments, and also what it's like to present at conferences. So essentially students will be given a topic throughout the semester. They have to present on that topic. There'll be some quizzes once the presentations are over. And then there are also some case studies for discussion throughout the semester as well. So classes will only meet for about an hour. So what are the learning theories that this course is based on? Well, this course is primarily based on constructivism. So constructivism is where the students' learning is in their own hands and it is in their own responsibility. It is using what is called a flipped learning classroom where students are teaching each other and they're responsible and must be active in their learning process. So the presentation that I'm going to do is on medial tibial stress syndrome, or MTSS, and it's essentially looking at the treatment, evaluation, and return to sport methods for MTSS based on the most current literature. So this is what I would expect a second semester graduate student to be able to learn, discuss, and create, and really ensuring that they're able to incorporate the best possible literature for this topic for them. So going into learning objectives. So summarize. So summarizing the evidence-based evaluation methods for MTSS, analyzing evidence-based evaluation methods for diagnosis and differential diagnosis of MTSS, design appropriate treatment plans, and return to activity guidelines for patients with MTSS as well. Oops. All right, so kind of a quick overview. What is medial tibial stress syndrome? Medial tibial stress syndrome is commonly referred to as exercise-induced associated leg pain and or shin splints. There's a lot of inconsistent AMS definitions, but the most consistent definition in the literature is pain at the posteromedial border of the tibia with pain on palpation of at least 5 centimeters. Some differential diagnoses for medial tibial stress syndrome are stress fractures and acute and chronic exertional compartment syndrome. So first thing we're going to do is we're going to discuss how we evaluate MTSS. So MTSS can almost be diagnosed with almost perfect reliability in clinical practice. So we don't need to use imaging or other sources. We can use ourselves as practitioners to evaluate and diagnose for MTSS. MTSS is also multifactorial in nature, so there's not one specific cause that we can say, like, this is what caused MTSS. We also must rule out other differential diagnoses of exertional compartment syndromes and stress fractures while we're evaluating for MTSS. So patient walks into your athletic training room and you kind of want to just grab a brief history. So my shins hurt. All right, so you kind of want to get a gauge in terms of their pain using various pain scales and other means. You also first want to ask of them, hey, is there pain at the distal 2/3 of the posterior medial border of the tibia? If they say no, well, we're not looking at MTSS. We have to continue our evaluation and see what's going on. If it is, well, great, we can continue our evaluation. Does the pain occur during or after activity? And is the pain reduced with rest? Also, it's important to ask, have you changed your training at all? If they've changed their training drastically and they're doing like maybe 15 more miles as a runner a week in cross country, then that's huge. So if it does, then yes, we have to continue to evaluate for MTSS. If the pain does not occur during or after activity, it is not reduced with rest or changes in training, then we maybe need to look at some other potential diagnoses. Does the patient have a previous history of MTSS? If they do, then they're more likely to be susceptible for another case of MTSS. So we have to ask them as well. If they've never had it, it doesn't mean they don't have it, but we still need to make sure that they don't have anything else going on. Important to ask the patient, do they have any cramping, burning of the posterior compartment, or do they complain of any numbness, pins and needles, or tingling? If they do, we need to definitely refer. It's a red flag for potential compartment syndrome. If they don't, we can continue our physical exam of medial tibial stress syndrome. Oops. All right, so we then want to go to our physical exam. So does the patient have palpable pain at the distal posterior medial border of the tibia, and is it greater than 5 centimeters? If the pain is less than 5 centimeters, then we definitely want to refer them for more imaging and potentially a tibial stress fracture. If it's greater than 5 centimeters, then we can continue on with our evaluation using some various tests, so the shin palpation tests and the shin oedema tests. So once we have been able to kind of understand that, yes, they do have MTSS, we've been able to rule out some differential diagnoses, we want to kind of look at a patient's strength. So hip abductor strength, quad strength, hamstring strength. So just kind of evaluate their strength, evaluate their posture for their feet, their hips, and everything else in terms of a general diagnosis and examination. So a lot of people always ask, tuning fork. Is a tuning fork a reasonable means of diagnosis? Well, results really don't support the use of a tuning fork or ultrasound as a standalone diagnostic test. There's a lot of support that isn't there, and it must be critically evaluated because there's a lot of conflicting and limited information. So this can be part of our evaluation, but it is not something that we should always rely on. It cannot be the end-all be-all part of our evaluation because there's so much more that we can rely on as clinicians. So, imaging techniques. So, when a patient has MTSS, we really don't need to get imaging unless they have pain that's less than 5 centimeters on the posterior medial border of the tibia. So, X-rays will generally be unremarkable unless there has been a stress fracture. A bony callus will be apparent on the X-ray, and that's after some healing has occurred. MRI and bone scans can show high signal along that border, but only when injury has progressed. So probably wondering why I have a duck on my screen. If it quacks like a duck, it walks like a duck, it talks like a duck, it's probably a duck. So we don't need to use imaging to rule in or rule out this diagnosis. We can use what we know as clinicians and what we know as special tests to help us rule in this diagnosis of MTSS. We don't have to rely on imaging. We don't have to rely on other things. So how do we appropriately manage this condition? So we have a patient diagnosed with MTSS. We've ruled out other conditions. What do we do next? So what are some different treatment models? So a study looked at a couple different types of treatment. So iontophoresis, ice massage, phonophresis, laser, periosteal pecking, bracing, graded running, extracorporeal shockwave therapy. And among all these different studies, amongst the critical review, there is basically bias methodologically, and it prevents them from recommending any high quality treatment. The one thing that they did find, that extracorporeal shockwave therapy could be promising, but further research in this area is needed. So extracorporeal shockwave therapy actually showed a more significant improvement in the treatment group than the exercise-only group. The exercise-only group was only able to run for about 4 minutes, and extracorporeal shockwave therapy was able to run about 17 minutes. It's important to note that for a patient to receive the type of treatment, they have to see a physician that has been trained in extracorporeal shockwave therapy, and it takes more than one session. So it's not exactly the most easy thing to do or get or have to pay for treatment-wise, just because it has to be done in such a controlled setting. So treatment of medial tibial stress syndrome, according to another model, so the fascial distortion model. So it's a type of massage that they're doing. So essentially they're using their thumb and it's applying strong local pressure with the tip of the thumb along that area of the tibia and kind of really massaging in there until pain has been decreased and really digging in there. So it's a very long type of massage. It's very painful and it's challenging for the clinician because you have to really kind of work into that tissue. There was some good evidence found by it, but important to note that the level of evidence was not very high. So it's something that we can consider a tool in the toolkit. Just doing some general massage for our patients in that area might be a good idea, but we don't have to necessarily crank or dig in on that area for our patients. Looking at strengthening. So strengthening of the core and hip musculature may help improve the gait and running mechanics to prevent lower body injury. So it's not an end-all be-all, but it's definitely something that we should consider as clinicians to ensure that patients are strong in the hip and the core, so they can generally have better biomechanics. It is important that the study did note that is limiting strengthening during the acute phase, just because of the strain that it does place on the tibia. It could potentially make a case worse and have other issues. Another randomized controlled trial looked at a graded running program. So one group was just graded running, another group was graded running with flexibility and strengthening of the calves, and another one was graded running with compression stockings. So this is a randomized controlled trial, so great level of evidence. What they found was there was no significant difference in time to complete running programs or satisfaction between treatment groups. So graded running program with flexibility, strength training, compression stockings, what may be it, wasn't really significant in any sort. But the average time to complete the graded running program was about 102 days. So definitely pretty long to complete this graded running program. So what's the answer? We've had a lot of different literature. So, based on this literature, we could definitely have to use our best clinician, evidence-based clinician knowledge to kind of come to a conclusion, because there's a lot of literature out there, but it's not the best literature and it's not all conclusive. But what we do know is that we have some idea as to what we can do to help our patients. So the biggest thing is resting and unloading our patients and ensuring that we decrease the acute phase of inflammation. We're also using massage, extracorporeal shockwave therapy. We're increasing the lower extremity chain strength, and we're also doing a progressive return to running program. So we need to use the best available evidence to our knowledge. So just some general return to activity guidelines. Phase 1 of a protection program, weight bearing is tolerated for the patient, decrease the volume of impact training by at least 50%, so cross training. So that's aqua jogging, Ultra G training, biking. So just decreasing the load on the patient. Avoid any painful load. If closed kinetic chain exercises can be performed without pain, let's go ahead and do it. We also need to identify any weaknesses in the lower extremity chain, especially in the hip abductors, to ensure the patient is as strong as possible when they are doing their running or their sport. And progression to the next phase of treatment is no pain with any types of physical activity or active daily living activities. And while also that, and reduce point tenderness when palpating the shin. Phase 2 is the rehab phase. So people ask orthotics. The literature currently does not show that it helps or does not help. So if it helps a patient, that's great. If it doesn't, that's okay. It's not something that we have to do. It's not something that we have to rely on, but it's definitely an option for our patients. It's important at this phase to begin a functional run-to-walk progression. Also begin more open and closed chain exercises, mixing it in, and then also basic weight-bearing exercises. So phase 3, dynamic balance exercises. So really challenging a patient with different types of exercises that are, more control. They have to use more control, more aggressive plyometrics, so more jumping and bounding and hopping. So they have to also complete the run to walk program in this phase. And the biggest thing for a patient to complete in this phase is pain-free running on successive full days, which is 3 days of running, no pain. Let's return them to activity. So if they can run and do their sport multiple days in a row and they have no pain, let's get them back into activity. So that's kind of a good gauge as to whether or not that we can get them back into activity. So what about less severe cases? So not every case that we discuss will present as severe as was discussed in the protocol. So we really must modify and restrict their activities that provoke their symptoms. So maybe they take only like 3 or 4 days of modifying their training, and then we progress them into sport while also strengthening them. You know, there's a variety of ways that we can do this. And again, we must use the best available evidence as clinicians as possible. So key points for clinical practice. One of the most accepted theories for MTSS involves damage to the bones. Risk factors for MTSS include being female, higher BMI, increased navicular drop, and increased hip external rotation. Rest for patients may be what's optimal, and ensuring that we are doing a gradual return and reevaluate training programs for patients as well might be key. So this is just a case study that we're going to discuss today. We have a 17-year-old Taekwondo player who has a complaint of pain in the lower leg bilaterally, has difficulty to take part in training sessions and matches. Patient comes in the athletic training room with a complaint of pain in both legs, anteromedially, distal 1/3 of the tibia, which started 20 days ago. As reported by the patient, he had incidents of an ankle sprain right side 1 month ago. He took treatment and gradually started his training schedule. When his occupational history was taken, he is a pretty high-level player with 3.5 years experience. He was training on the hard surface for 5 months with a high intensity, and the duration of training was long. Before training, he also performed warm-up and cool-down sessions for every session, or for every activity and session. The pain history was gradual, was about 15 days. It's dull, aching. It's localized, so it's that distal 1/3 of the tibia, 6 centimeters long. It's on the anterior medial surface of the tibia. It's aggravated by jumping, kicking. It's relieved by some icing and just rest. So this patient also practices on some rough terrain. They do have some sleep disturbances, and on the visual analog scale, they report 3 out of 10 with pain on rest and 6 out of 10 with activity. So just kind of looking at his posture, definitely some pes planus, so lower arches. The patient also has normal range of motion, normal end feel, and normal manual muscle testing for the feet, lower extremity. So for this patient, what can we do for a treatment session to return him to activity? What strengthening things can we work on to return it to activity? And how can we modify his training to return to activity? So definitely in a case study that we can take a look at today in class. And that is it. And here are some references. And thank you again.